My training is in pediatric infectious diseases, and I see adults and children with primary immune deficiencies at NIH. And I like this kind of smaller setting compared to yesterday where it was like a huge room. Seems a little bit more relatable in here now. Okay, so, it's kind of a broad topic, but, so we can, at the end, go through your questions and kind of decide where to go from there. But what I'm going to talk about is some of the different fungi, and then also kind of approaches to antifungals kind of thrown in with that. And we're going to kind of focus on three main categories of fungi. The yeasts, which are when they look like little circles like this, instead of kind of branching things like this, which we see in molds. So yeast, this is an example of Cryptococcus, which we'll talk about more in a little bit. Candida is another common yeast that a lot of people hear about and very commonly cause infections. And then we'll talk some about the dimorphic fungi. Dimorphic means that they have two forms. So they can either live as yeast or they can live as filamentous molds, so branching molds. And the ones we'll touch on are Histoplasmosis, and I'll talk about Coccidioides. I'm not going to talk about Blastomyces, but I'm happy to if people want me to. And then we'll talk about the classic filamentous molds. And here are just some examples. Aspergillus, and you can see here, this is inside tissue, but you can see the kind of branchingness to it. You can see it branches right there. And then Scedosporium is another example. And this is actually a picture from one of my patients who had a gastrointestinal histoplasmosis infection, and the little black circles are histoplasmosis in its yeast form. So I'm going to start with Candida. Candida is very, very common. Candida is part of our normal flora. So Candida is, if you got fungal cultures of otherwise healthy people, even if you don't see it causing disease, you can grow Candida. But, Candida can definitely cause problems, and Candida can cause very serious problems as well. Typically, if it over-proliferates, for instance, if you're on some antibiotics that kind of wipe out the normal bacteria in areas, then you can have a little bit too much Candida there. Or if there's a breakdown of the normal barrier. So one of the times outside of primary immune deficiency where we can see really severe Candida infections is in the ICU setting in people that have gastrointestinal surgery. Because everyone's GI tract has some Candida in it, and if you break down that barrier, people can get really sick with Candida. But I'll talk a little bit about two different types of candidiasis. One is mucocutaneous disease. This is what we see most commonly in individuals with primary immune deficiency and outside of primary immune deficiency in otherwise healthy people. So, oh my gosh, this is very sensitive here. It's like if I touch anything, it moves. Okay, I'm going to try not to put my hand at all on the keyboard here. So mucocutaneous candidiasis. I don't think there's a pointer. But you can see on the top right picture there, that's an example of thrush. Really common and normal in young babies and infants. It's normal to have thrush, and you can see little white patches on babies often that have thrush. But this is an older person, obviously, with the teeth. Everything okay? And other examples of mucocutaneous disease is vaginal yeast infections, really common, otherwise healthy women. Esophagitis, it can either stay in the mouth or the Candida can actually head down into the esophagus, which can cause a lot of pain with swallowing and kind of feeling like food is getting stuck. Candida can cause skin infections. It likes kind of like warm, moist areas, so like kind of in the groin, those areas, and can cause fingernail and toenail disease. You can see there's a picture there of one of my patients with multiple fingernails involved with candidiasis. That's someone with an underlying disease of hyper IgE syndrome. So I'll talk a little bit more about, which primary immune deficiencies actually, result in having trouble with Candida. It's usually those that affect what we call the Th17 pathway. I'll show all of you a picture of that, but it's a certain type of lymphocyte. So we see it a lot in people with loss of function STAT3, which is Job syndrome or hyper IgE syndrome, gain of function STAT1, APASED, and there's a lot of sessions on APASED over yesterday and today. And then just commonly for a lot of people with primary immune deficiency, because a lot of people with primary immune deficiency end up on antibiotics, or on inhaled steroids or on systemic steroids like prednisone, and all those things can make you have more trouble with Candida on, for instance, in the mouth or in the skin. And I just put a little thing there, on the inhaled steroids. This is why people always say, it's really important to wash your mouth out afterwards because inhaled steroids are for the lung. But, when you're doing that little puff, it can line the inside of your mouth and you can end up with thrush really, really easily. Of note, Candida does not, except in extraordinarily rare circumstances, cause pneumonia. It really sticks to kind of the upper mouth and can go down the esophagus, but not actually cause classic pneumonia. Okay, and then there's invasive disease with Candida. So this is, the really serious Candida infections, like bloodstream infections, meningitis, liver and spleen infections. These are not typical of primary immune deficiency, except if something else is going on. For instance, with people with have a central line, if you're on antibiotics and your skin is more colonized then with Candida because you're wiping out some of the normal skin flora, sometimes then, you can have Candida kind of creep in and cause a central line infection post-surgery. There is one primary immune deficiency that really predisposes to bad systemic Candida infections. That's with Candida meningitis, and that's called CARD9 deficiency. And then we see troubles with Candida in individuals that are neutropenic, where it becomes more invasive, such as after chemotherapy and in the bone marrow transplant setting. And most individuals undergoing things like bone marrow transplants are on some sort of prophylaxis to prevent Candida from being an issue. So I just thought I would throw in, most of this session is going to be just kind of practical and kind of guides to antifungals, but I thought I would just show in a little bit about kind of how Candida is controlled by the immune system. And so I'm looking for the pointer. So you can see here the big circle is an epithelial cell. And so that would be, for instance, the surface of your mouth. So your mouth is lined with epithelial cells. Those are like skin cells. And then the little circle to the right up there, that is a Th lymphocyte. So that is one of the T lymphocytes. And that's one that, depending on the inflammatory milieu, lymphocytes can kind of grow up and develop to do certain things. So, for instance, they become something we call Th1 cells, which are really good at killing like bacteria inside cells, or they can become Th2, which is more kind of causes things like allergies, or T regulatory cells, which causes things like autoimmunity. Anyways, for Candida, it's really important for these lymphocytes to become these Th lymphocytes, Th17 lymphocytes that are really good to control Candida. So you can see the little yeast, that's a little I think it is, I don't know if it's an octagon maybe there. The little orange one binds on its receptor on the mouth cell, which is dectin-1, goes through a couple different things, including CARD9, and then the red explosion right there with the IL-6 and IL-23, these are different inflammatory molecules that then, through things like STAT3, which is a signal transduction protein, causes those lymphocytes to grow up to become the Th17 cells. They then secrete all these other little inflammatory molecules to talk to the other cells in the area, which then cause these antimicrobial peptides, which are exactly what it sounds like. It's anti-microbe, so in this case it's anti-yeast, and then peptides are just very, very short little proteins. So we know on all those areas where I put X's, those are all genetic defects that can then predispose individuals to have trouble with mucocutaneous candidiasis. So STAT1, STAT3, CARD9, probably something with dectin-1, IL-17, and its receptor IL-22 there. And I just put some of the research that's been done at NIH, kind of looking at this pathway on top. That's looking at the number of Th17 cells. Now, this is with hyper IgE syndrome, which I study from STAT3 mutations. And the little orange circles in the middle there show that lack of those cells compared to the green circles next door, which are from otherwise healthy people, showing that you can't develop those type of white blood cells. And in the bottom graph, this is looking in the saliva to see how much of those antimicrobial peptides that are supposed to be out there killing the yeast are really present in the saliva. And you can see the top bar on the left, those are otherwise healthy individuals with a lot of that protein, and right next to it, the lower protein there. Okay, that was our brief little science lesson there. So how do we treat Candida? So a lot of times, if someone just has thrush, you can treat that topically, and that's true for vaginal yeast infections too. So I put down some of the therapies there. There's nystatin, that's kind of the, one that's been around forever. Not, super effective if things are severe, but it works really well for babies, and it can work really well if it's not a significant infection. So you can either switch that around and spit it out, or you can swallow it if there's any concern about the esophagus being involved. There's also troches. These are like lozenges that you can suck on with different azoles. So some of my patients like the clotrimazole troches, where you have to use them every few hours. But again, then you're not taking something that is systemically absorbed. This is something where it just works locally. Amphotericin, which we'll talk about a little bit lower down, is like a kind of a hardcore intravenous antifungal. But pharmacies can sometimes make a suspension of that you can swish around in your mouth and even swallow if you have disease going down the esophagus. For vaginal disease, there's different suppositories and creams. And then I took a picture of kind of the thing that's been around for like 50, 60 years, maybe even like 100 years, is something called gentian violet. This is really messy. I don't recommend doing this unless you have something else going on. But you can see the little babies turn totally purple there. But, it does work. It can be a little bit irritating. But if things are just not working with anything else, rarely we'll get that involved. Systemically, the oral antifungal that's used the most is fluconazole. It's very well tolerated. It has minimal liver toxicity as a side effect, but generally people do very, very well on this. I didn't put this up there, but something we don't talk about that much in these sessions, which we probably should talk about more, is what can you be on when you're pregnant? Fluconazole, you're not supposed to be on, at least for the first several months of pregnancy. And other azoles as well have Candida activity. Oh, thank you. Now we have a pointer. This will be fun. Yes. So if there's resistance to fluconazole, some of the stronger ones sometimes work, like posaconazole or voriconazole. And we'll talk more about their side effects later. Systemically, if there is a more severe Candida infection, extremely well tolerated, but only available in intravenous form right now, are the echinocandins, which is caspofungin, micafungin, and nidulafungin. Those are given once a day. Again, really well tolerated, just annoying because they're IV only. Hopefully, in the near future, we'll have some that are oral available. And amphotericin, pretty much all Candida, 99-point-something% of Candida is sensitive to amphotericin. But amphotericin is only IV when it's given for a disseminated infection, and it can be very toxic for kidneys. Okay, moving right along, Cryptococcus. This was the other Candida that I showed a picture from a couple slides ago. So Cryptococcus is a yeast. It can live in bird droppings, decaying wood, and there's a couple different species. The most common one is called Cryptococcus neoformans, which is very widespread and doesn't usually cause troubles for people that are otherwise healthy. And then there's Cryptococcus gattii, which is mostly in the Pacific Northwest in this country, so in Washington State and in Vancouver areas. Cryptococcus is in the environment. As I said, it's often kind of with things like bird droppings, especially with the neoformans. And so then you can breathe it in, and it can cause a lung infection. This is an example of what a Cryptococcus lung infection looks like. So for everyone that doesn't look at CTs very much, I talked about this yesterday at my session, but when you're looking at a CT, we'll just make sure everyone knows, you have to be standing, you have to imagine yourself standing at the foot of the individual, and that person is lying on their back. So you're looking towards the head. So this is the right side, and this is the left side. And this is a right-sided lung. So this is the right lung, and this is what normal lung tissue looks like. This is the heart in the middle, and this is the left lung. That's the backbone, and this is kind of the chest bones in the front. So this is an abnormal area. You don't see that on the other side. And that's a nodule from Cryptococcus. So this is what it looks like if you actually breathe this in and it causes an infection. These often don't give very many symptoms. And really, the lung disease is not so much a problem. The problem is that it can go from the lungs into the brain and cause meningitis. Sometimes, if people have bronchiectasis, things in the environment then often stick in the lungs, and sometimes you can grow this without it causing many problems as well in the setting of bronchiectasis. But when you have something like this, you really need to think about, the possibility of it spreading to the brain. And when you have meningitis with this, people do become symptomatic and have fevers and bad headaches, and often the pressure in the head is high and can have some visual changes. But it's not super rapid onset like a bacterial meningitis. This can happen over days or weeks and cause problems. So which primary immune deficiencies have trouble with Cryptococcus? Where we really see this is in the HIV population when the lymphocytes are very, very low. And so in other settings where you have very low CD4 lymphocytes, you can see Cryptococcus meningitis. There's this entity that we don't always understand called idiopathic CD4 lymphopenia, that primarily affects adults. It's a primary immune deficiency that's probably a different, it probably has multiple causes in it, but we see Cryptococcus meningitis probably most commonly in primary immune deficiencies there, rarely in hyper IgE, Job syndrome, gain of function STAT1, GATA2 deficiency, and then this entity called anti-GM-CSF autoantibodies, where your body is kind of like autoimmune making an antibody against this one inflammatory molecule that helps some of the white blood cells grow. That can cause both a lung disease called pulmonary alveolar proteinosis, but also can predispose to Cryptococcus meningitis, specifically with GATI. So how do we diagnose this? You can look for evidence of the fungus in the bloodstream. It's just looking from a protein. It's called a Cryptococcus antigen. If you do a spinal tap, then you will see that protein of the Cryptococcus in the spinal fluid, and you can also grow this on culture. The treatment is with amphotericin intravenously if there is evidence of brain infection, followed by fluconazole. For prevention of this, fluconazole, or pretty much anything that ends in azole, is very good at preventing this infection. But we don't, it's usually given for people that have very low T cell counts or considered if you're in that kind of West Coast area, if you have the problem with GM-CSF autoantibodies. Histoplasmosis. So histoplasmosis is another one of these dimorphic fungi that when they're inside your body, they look like yeast, the little circles, and when they're out in the environment, can look more like with branching kind of molds. They are in the environment. I put up the CDC map of where this is mostly. The greener it gets, the higher the concentration. So here we are right outside it, but there is a little bit probably, there's a little bit of histoplasmosis in Maryland. The areas where you really think about histoplasmosis is kind of, southern Illinois, Indiana, and all kind of the diagnostic tests that people do for histoplasmosis is all based out of Indiana. Kind of along the Mississippi River Valley. We've actually seen severe cases in Mississippi itself. This is in the environment. Also, it's often in the dirt. Bat droppings is a really big deal. And if you have a primary immune deficiency that predisposes to this, it's a really not a good idea to do things like going cating or spelunking where there are bats, because this can cause a severe infection then. Also in construction, so you think about it in Indiana, construction sites where things are really kind of getting into the air from the dirt, that can predispose to this infection as well. This is usually breathed in, it causes a lung infection, and then can spread, sorry about that, why? It can spread other places in the body, such as in the GI tract, lymph nodes, liver, spleen, blood. And the primary immune deficiencies that affects hyper IgE syndrome, GATA2 deficiency, which is usually presents in adolescents or adults. And then along this kind of specific pathway of how the macrophage white blood cells and the T lymphocyte white blood cells talk to each other. It's the IL-12 interferon gamma receptor STAT1 pathway, and then in certain combined immune deficiencies. This is not usually a problem in a pure B cell problem, such as XLA or CVID. Diagnostically, we test this, again, looking at an antigen, so looking at a protein from the Histoplasma fungus in the blood and urine, and we can also do fungal cultures. Treatment, if severe, is also, again, amphotericin, and then usually itraconazole or posaconazole. If it's not severe, you can start with one of those. Otherwise, healthy people, you don't treat this. It usually causes kind of self-limited lung disease. Oops. Coccidioides. This one is very specific to the American Southwest, most common in Arizona, but there's been a bunch of articles in newspapers and all over the place, CDC, recent years about kind of the spread in California. And it is spread often in dust storms or working in the dirt where you see this. This causes something called valley fever. So in people in Arizona, it's usually kind of self-limited flu-like illness with a cough. But in certain primary immune deficiencies, and again, these are very specific primary immune deficiencies, it can spread to brain or bone, and then usually causes a chronic infection and can be really hard to fully cure and control. So specifically in gain-of-function STAT1, STAT3, and some combined immune deficiencies when the lymphocytes are very low. It's just something to be aware, primarily if you're going to California, to Arizona, or kind of more the deserty areas of California. The diagnosis by urine and blood. This is a harder one to culture. It's not as much hard to do a culture of if you have something like the lung, from bronchoscopy or biopsy, except that it can be very dangerous to the lab to culture it. So it's something that we kind of take seriously as infectious disease people to make sure that we don't harm anybody working with it in the lab. The treatment is very similar to the others, amphotericin, bifluconazole, or other azoles. And this is easily prevented by fluconazole as well. So for my patients, for instance, with hyper IgE syndromes, if they live in Arizona, I had them on at least fluconazole for prophylaxis. Okay, moving on to molds. So molds, Aspergillus is the one that we hear about most commonly, which, it's kind of a cute picture of Aspergillus. This is what it looks like when it grows in spores. This is like if you had fuzzy bread or whatever and looked at it under the microscope. So Aspergillus is all over the place. I mean, these molds live in the environment. They're all over the environment. You can't get rid of these things. But it's kind of like trying to minimize the damage that they do. But it's impossible to totally be rid of this. They typically cause lung infections, sometimes sinus infections, rarely outside of the lung, usually only in the setting of severe kind of low neutrophils does it go outside the lung, or in the case of chronic granulomatous disease. Again, even in chronic granulomatous disease, rare to go outside of the lungs. We see this causing much more invasive disease also in bone marrow transplants or leukemia. But Aspergillus can do a lot of other things besides the very severe invasive disease. It can cause destructive allergic disease, which I'll talk about with ABPA, and can cause Aspergillomas inside lung cavities. So we had to highlight here, this is in the world of primary immune deficiency, there is very, very, very little data about what we do for prophylaxis against infections. We borrow that from things like HIV or bone marrow transplant settings, but in terms of studies done that are properly done with the proper controls in primary immune deficiencies, this is kind of it in terms of a blinded study. So this was done back in 2003 is when it was published. I was a fellow at the time, so this was like a big deal. We did this for Journal Club and stuff. This is before I worked at NIH, but study was out of NIH. And what they did is they took individuals with chronic granulomatous disease, and they did a couple of years on itraconazole for prophylaxis against molds, and then they did, a placebo. So a year on this and a year of placebo. And so the individual didn't know, and the people taking care of them, like Dr. Gallen and Dr. Holland, didn't know either. And what they found was that when they were on the placebo, you can see this list of all these Aspergillus infections that happened. And when they were on the itraconazole, they only had one breakthrough infection. So this is not perfect, but is it's pretty good, in terms of preventing mold infections in the lung, which are fairly common in chronic granulomatous disease. Back then, in the early 2000s, we didn't have, especially in the 1990s or any time before that, we didn't really have any good oral drugs to treat molds. Back then, you had to wait till you got your mold, and then you got amphotericin. And recently, we have much better preparations of amphotericin. Back then, it was these very toxic forms of amphotericin. I actually recently, one of my patients had to have chemotherapy for lymphoma, and he's in his 60s, and he had gotten amphotericin a lot when he was like in his 20s, and he was like, this chemo is nothing compared to the amphotericin. I mean, it was that bad back then, So when we finally got oral drugs that could treat Aspergillus, this was huge. So itraconazole was the first one that came out, and then voriconazole came out, and then posaconazole came out like in around 2006, and then most recently was isobuconazole. So we don't really know, this data, if we did this with posaconazole or anything. No one's done this again. But all the other ones, posaconazole, isobuconazole, and voriconazole, are stronger against molds. But itraconazole is very safe, and it tends to be used for prophylaxis in this setting. So just to talk a little bit about these, Itraconazole, they used it mostly as a capsule in adults, liquid in children. The capsule form's not as well absorbed as the liquid, and in general, you have to have more of an acidic environment to absorb these. So for people that are on acid blocker, it's a little bit harder to absorb the itraconazole. Posaconazole is very well tolerated. Voriconazole, I'll show pictures of later, but can cause photosensitivity and fluoride toxicity. And these ones can cause some liver issues, not commonly, but especially if you combine them with other medications or if you have underlying liver disease, they can cause some liver dysfunction. And these, like itraconazole, can interact some with prednisone. So it decreases the metabolism of the prednisone. So if you're on itraconazole and prednisone, it's possible that your prednisone dose, if it's 5 milligrams, maybe it actually feels like 10 milligrams, for instance. Okay, so this is talking about chronic granulomatous disease with Aspergillus infections. The symptoms, most of the time, are fairly indolent, kind of slowly come on people. There's cough, there might be some low-grade fevers, chest pains. They tend to be less symptomatic than a bacterial infection where you get sick quickly. With the one exception of what we call mulch pneumonitis. When people with CGD breathe in kind of a high load of mold, they get this widespread inflammatory reaction in the lung. And you can see a picture here. This is a chest x-ray, and a lot of these lungs on the right and left should all be black, but it's all white because this is just inflammation all over the place from breathing in this. And you can imagine if that's what your x-ray looks like, your oxygen levels are going to be very low and you're quite sick. And to treat this, we use antifungals as well as prednisone to decrease the inflammation. The diagnosis in CGD of having a mold infection is with imaging, typically a CAT scan to see where the source of infection is. And then really importantly for chronic granulomatous disease, you can't make this diagnosis very easily with a bronchoscopy. You have to do a biopsy. We usually start with a needle biopsy with interventional radiology to do this. The treatment, most Aspergillus responds to these azoles, posaconazole, voriconazole, isavuconazole. Itraconazole, again, is more for prophylaxis. It's important to monitor the levels and the liver function test, and then follow up imaging to make sure there's a good response to therapy. Okay, now switching away from chronic granulomatous disease, we'll talk a little bit about ABPA. This is allergic bronchopulmonary aspergillosis. So this is it's not considered an invasive Aspergillus disease. There can be local, a little bit of invasion, right, where it's sitting in the airways, but not like the big pneumonias that you get with CGD and mold. So this is more of an allergic reaction or hypersensitivity to the actual mold, so to the proteins of the mold. And it's most commonly with Aspergillus, but you can see it with other molds, like Scedosporium, for instance. And this is what the imaging would look like. So on the left here, this again is the left lung, the black is air, and that looks pretty normal. These is kind of the normal airways that you see in blood vessels. But you can see here these white kind of mucus that's impacting these airways, and the airways become very dilated in this setting. And that's what it looks like if you have ABPA. You kind of see this pouring out of all this really thick mucus into the airways, and it causes the airways to then expand. And then once that clears up, you're left usually with what we call bronchiectasis, which is kind of abnormal airways in the chest. So this usually happens in people with asthma, cystic fibrosis. Also, we can see this in hyper-IgE syndromes. And the symptoms usually with wheezing and cough, you can have productive sputum. Usually it looks kind of brown, like as if you had little mold spores in there. The diagnosis usually is with a consistent chest CT and then high serum IgE. This makes it really hard in hyper-IgE syndromes to actually make this diagnosis. Blood tests to look at actually, are you making IgE that's specific against Aspergillus? And other kind of blood tests. You can do allergy skin testing to Aspergillus if your lungs are in pretty good shape. Sputum cultures often will grow Aspergillus, but that's not necessary because there's not usually a ton of mold in there. It's more this huge inflammatory reaction to the mold. And if you look at the sputum, it's usually filled with these type of white blood cells called eosinophils, which are common in allergy. The treatment is really at the allergic reaction. So it's usually with prednisone, plus or minus antifungals. I use antifungals for people with primary immune deficiencies because the last thing you need is to weaken the immune system more with prednisone and have a mold in there. So I use the both together, keeping in mind that they can interact a little bit. And every once in a while, we'll use omalizumab. The trade name for that is Xolair, which is an anti-IgE monoclonal antibody. I tend to use that if the individual can't tolerate prednisone as well. Then there's Aspergillomas. So, people with bronchiectasis and people with hyper IgE syndromes can form cavities in the lung. This is a chest CT of someone with hyper IgE or Job syndrome, and you can see the large cavity there. And then once you've kind of messed up the architecture of the lung like that, like once the architecture is different and there's a hole in the lung, as I said, we're all breathing these molds, all the time. There's nothing we can do to prevent that. But, they like land in your airway and you cough them out. But if you have a hole there where the mucus can't easily get it out, then the mold gets stuck in there and they form these little balls, and that's what we call an Aspergilloma. The symptoms of that, usually people do have a cough. You can sometimes have chest pain. Often these cause people to cough up some blood. And the diagnosis is doing chest imaging, such as a CT. You can also see these often on chest x-rays to diagnose the cavity with the mold ball inside it. So usually the hole has predated this, but you don't always know that you have a hole in your lung because that can be without any symptoms. The treatment is really tricky here because this is sitting inside a cavity in the lung, so there's no blood vessels going inside the cavity of the lung. And if you take a pill, right, you're relying on the blood vessels to get the medication to that spot. So, I still tend to use them because usually what happens to cause the bleeding is that pocket of infections eroding the little blood vessels right next to that, and I find it helpful then to be on something, and I think it minimizes the amount of bleeding that occurs. If there is kind of recurrent bleeding, often people will do surgery and just remove these. That doesn't work so well in people with hyper IgE syndrome, but in other settings it can be considered. Sometimes we'll use inhaled antifungals. Again, though, sometimes it can be hard to get into these cavities, but people have used inhaled amphotericin and inhaled voriconazole. Occasionally, and this is not by any means first, second, or third line, but occasionally we'll also put a needle in here and inject like a gel with an antifungal inside there. And then, probably what happens the most in primary immune deficiencies is for people with things like CVID or XLAs, you end up having some degree of bronchiectasis, and your airways have mucus that gets stuck in them, and they tend to be sticky, and Aspergillus or other molds in the environment will just stick there. And you'll have positive cultures if people actually do the fungal culture and not just the bacteria culture, and you'll grow molds, in your cultures. And it's really hard to interpret those cultures. Like, does that mean anything, because, a lot of times it can just be transient colonization and actually causing diseases. Probably the most common one to grow is called penicillium. This is in the environment. This rarely in this country causes disease, the species we have of it in this country. But it often grows, and if you see that popping up in your own fungal cultures, don't worry about that one for the most part. You can always talk to your doctor about it, but most of the time that one does not mean anything. But, we do sometimes treat this. It used to be the dogma was like, oh, you don't treat if it's bronchiectasis and you grow molds, because of course you can grow molds. But if you ever repeat positive cultures for them, plus increase some symptoms, and, maybe having some hemoptysis and some worsening change in your imaging, we do often add something to treat these, usually, something like posaconazole. So then, the other thing with molds is trying to avoid them if you have lung disease. So, people with chronic lung disease and CGD, which is specifically predisposed to these because the neutrophils can't kill the mold, cavitary lung disease, like I showed that picture of, significant bronchiectasis, asthma, try to avoid the high mold exposure. So there's my little X instead of a big X against mulching. Hay rides are not a good idea in this setting. Mowing the lawn where things kind of fly up is not a good idea. But, you can't eliminate everything. If you see a big patch of mold in the house, it's good to address these things. But everyone has mold. It is everywhere, and it's just kind of minimizing it is the way to approach this. The other thing that comes up more and more frequently is that, a lot of people, smoke marijuana to deal with chronic illness, but, marijuana is frequently contaminated with mold. So just to be aware of that, and things like filters can help, or edibles, but, I do not like it when my patients that have chronic lung disease are smoking marijuana with the risk of mold. How about antifungal resistance? In this day and age, we talk a lot about bacterial resistance, And antifungal resistance is a lot less common. But, it's becoming a little bit of a concern. For people that are on fluconazole a lot, there are, the Candida can become resistant, and there are Candida species that are resistant to fluconazole. It's really important if you think things aren't working, it's an easy one to actually do a culture of and have it tested against the common antifungals. And then, in Europe, there was an outbreak of some Aspergillus that was resistant to things like voriconazole because of pesticides that were being used that included azoles in them. There's been some concern in the last couple years. There's a newly kind of recognized species of Candida called Candida auris that's been causing some healthcare associated infections. Not that right now like a big deal for people that have the kind of chronic mucosal Candida, but it's something that we in kind of the healthcare fields are all looking at because it's more resistant to the typical azoles. And then, if there is something like an Aspergillus infection, we don't usually do antifungal testing up front because they're a little harder to determine, but it is something to consider if things going on. It's just important to talk to like an expert in terms of interpretation. And then just to kind of finish up, some trickiness in the antifungal dosing. Pediatric patients, kids metabolize azoles very differently than adults, and kids can need much, much more voriconazole than adults, for instance. And even the posaconazole. We have little children that are on the same dose of posaconazole as our adults. So it's really important, and these are medications where you can check a blood level and know whether or not you're dosing it appropriately. So that's really important to check it. Then, we've also had this happen. Posaconazole initially was only approved in the liquid formulation, and the adult dose of that was 400 milligrams twice a day of liquid. Then they came out several years later with a pill formulation. In the pills, it's much more rapidly absorbed, and you only need to take 300 milligrams once a day, typically, to equal 400 milligrams twice a day of liquid. So if you go from liquid to pill or pill to liquid, this happens sometimes when people aren't as used to using posaconazole, and then people get totally the wrong dose, and it can cause major liver issues if you suddenly give someone twice the amount. Itraconazole and posaconazole, liquid is better with acidic stomachs and with fatty meals. Posaconazole, if you can swallow a pill, it's much better to take the pills if it's tolerated because it's better absorbed. Itraconazole is the opposite, where the liquid is better absorbed. And then the photosensitivity with voriconazole is really real. When voriconazole was developed, it was developed for the bone marrow transplant patients. But our patients, like everyone here, live lives where they're going outside and they're leaving the hospital compared to the bone marrow transplant patient in the acute setting when they're not leaving a hospital. And, a little bit of sun, even indirect sun, can cause extremely bad burns and can lead to skin cancers for people on voriconazole. So just be aware of that. So just to finish up, and then we'll do questions. So Candida, part of our normal flora, but can cause some problems for certain diseases or if you're on steroids and antibiotics. The dimorphic fungi, knowing the part of the country is important only if you have one of those specific immune deficiencies. And molds are all over the place, and it's really just minimizing it if you're at risk. Thanks, and this is a picture of the NIH hospital, our clinic. Okay, we will answer some questions. Are there fungi that can infect the liver? If so, can the infection lead to cirrhosis and or NRH? So we do see fungi in the liver, so a couple different ones. So, because this is kind of broad with the fungi. Candida, especially after like chemotherapy, can infect the liver and spleen. That usually causes very small abscesses, and we can treat it appropriately without long-lasting issues. The dimorphic fungi like Histoplasmosis, those can also cause chronic infections. It's much more rare, but possible to see liver infections with Aspergillus. I think I've only seen that in two settings. One is chronic granulomatous disease. In CGD, chronic granulomatous disease, it's still very rare compared to the lung disease that we see. And the other time I've seen it is in card9 deficiency, which is also affects kind of how neutrophils can kill these things. So the NRH question, so the nodular regenerative hyperplasia is a chronic liver disease that we see in certain primary immune deficiencies, and we do see that in CGD. So that question of can fungi lead to that It's a little hard to know because we think some of the repeat inflammation infections do lead to some of the NRH in chronic granulomatous disease, but it's unclear exactly why and is not the typical reason for that. Is it common with CBID to test positive for strep constantly without typical strep symptoms? This one, I mean, that's for bacteria, and this is fungi. So, but it would be, people can be carriers of different infections. So I think that one, you know, you sometimes can be colonized with bacteria such as strep without actually causing disease. Let's see, is itraconazole as effective for voriconazole when used prophylactically? You know, they've never been put head-to-head to test them. Voriconazole, posaconazole are more potent antifungals, and most likely they do cover things more broadly, so probably if they're put head-to-head, you probably would see a little bit better activity with voriconazole. The thing is, with voriconazole, you also have more side effects, so that's why people tend to use itraconazole prophylactically. Are there experts in mold for PI patients? Yeah, so it kind of depends on the disease, for instance. So Dr. Leonakis, who's been here doing a bunch of sessions, especially yesterday with ABPA, which predisposes to a lot of trouble with Candida, he is a world expert in fungi, and he's at NIH. And he is my go-to person for a lot of those questions. But he sees people with invasive mold diseases as well. I've been on fluconazole daily for years, and I'm very prone to Candida. How worried should I be about my liver and or other problems? So some people, for instance, on CGD, you know, and some of the patients with hyper IgE syndrome that we take care of at NIH, people have been on azoles for decades without any liver problems. It doesn't cause things like NRH, which can be a little bit more subtle. When azoles cause problems with the liver, it makes the liver transaminases, the ALT and AST, go up. And so it's very easy to monitor this on blood tests. And people that aren't having many trouble, you know, if they've been on it for a long time, I usually just track liver tests, you know, one time when they come to see me at NIH, if it's the annual, and then one time at home, so every 6 months or so. When you first start them, that's when you need to monitor a little bit more closely. So usually when I started, I check about 2 weeks later, liver function tests. But it also depends on your underlying issues and other medicines you're on, how frequently I check liver tests. Anything to help prevent yeast infections when taking antibiotics? Already talked about probiotics, always have to take diflucan. That's really hard. I mean, you know, probiotics are helpful for some people, but, you know, the amount you need to take is sometimes prohibitive against that. Some people are just prone to having yeast when they are on antibiotics. You know, certain antibiotics cause more trouble with yeast. So sometimes things like amoxicillin clavulinate, that's augmentin, or doxycycline, or the fluoroquinolones like levofloxacin, they wipe out a lot of your normal flora. Some of the other ones that are more limited, like azithromycin or Bactrim, tend not to have quite as much trouble with Candida. You know, sometimes people can eat yogurt or take probiotics, it can help somewhat, but I think some people are just prone, and it's really hard to avoid then ending up on some diflucan or fluconazole. What are your thoughts on living with Aspergillus without treatment besides Xolair? So that's omalizumab. Would you try to eliminate or live it without symptoms? Okay, I'm trying to get this one. Maybe we'll talk about. I could talk to the person afterwards. I'm not sure exactly, but what the question exactly is. But this is probably ABPA. So you know, it's not a good idea to have ABPA not treated at all if there's a lot of mucus impaction in the lungs, just because if you're having an intense inflammatory reaction because of ABPA, you aren't going to feel well, and your lungs are going to get damaged as a result. So I think it is important to try to decrease the inflammation, if I'm understanding that question correctly, either through Xolair or prednisone, or even, you know, sometimes we'll use we'll do that, and then we'll do, you know, kind of higher dose inhaled inhaled steroids. They say that one dose of fluconazole is sufficient to cure a vaginal yeast infection. I need 14 days of it to clear it. Is this normal? So the one-day studies for yeast infections, that's all done in otherwise healthy women. So in people with primary immune deficiency, when people are on antibiotics, and the immune system by definition is not, you know, totally normal. So depending on its way, it's often people need different courses of therapy. Thank you.